Now let's look at some case presentations taken right from my practice. This is Seth W. He's a 27-year-old white male, and he comes in with physical exam because his girlfriend thinks that he doesn't look healthy. He comes in saying, "Hey doc, just give me a physical." He has no complaints, past medical is unremarkable, he's a landscaper by day, guitar player in a band on weekends, few beers a day, no smoking, no drugs, family history, his father has high blood pressure and depression, he's on no medications. Some review systems, he admits to occasional tiredness, but he says it's just from working hard. He does fall asleep easily while watching TV, so when he comes home at night, while a girlfriend is making some stuff for him to eat, he kind of finds himself dozing off. Now, in the last couple of years, he's never seen the ending of a movie, and his girlfriend is always kind of chuckling about that. But lately, she's not chuckling anymore. She's kind of upset. But also, the girlfriend says that he snores real bad. You examine him, and what you find on Seth is that he has a BMI of around 30. His blood pressure is a little bit high at 140/80. His Mayo-Patty score is around 3. You can barely see what's going on in there. And his neck size is around 16 inches. You do an Epworth on him, only takes a couple of minutes to do, and it turns out to be 14. Now here's a question for you. Which of the following are not Seth's risk factors for OSA? Elevated blood pressure, obesity, crowded pharynx, and a neck size equal to or greater than 16 inches. Now obviously, elevated blood pressure is a risk factor, as is obesity and crowded pharynx, but as far as the neck size, I'm trying to get the point across that it's more than 17 inches for men and more than 16 inches for women. So we should look at the neck size and try to correlate it with obstructive sleep apnea. So obstructive sleep apnea is strongly suspected in Seth because of elevated blood pressure, obesity, crowded pharynx, and his symptoms, that he snores and he's sleepy and he doesn't feel well. These are all suggestions of the possibility of obstructive sleep apnea for Seth. So what would be your next steps at this point, thinking of the possibility that obstructive sleep apnea is going on with Seth? Educate Seth about OSA, refer to sleep consultation or sleep study, order appropriate lab tests, begin conservative approach until diagnosis is confirmed, and all the above. Well, all these answers are actually correct. Educating Seth about OSA is definitely a good idea. We in primary care especially like to do that, where we educate about the condition that the patient is going through, no matter what the condition is. A person who knows what's going on can take care of their conditions better. Referring for sleep consultation is also a good idea. This patient has a high probability of this sleep disorder, and referring to a sleep clinic makes a lot of sense. Now, ordering the appropriate lab tests like fasting blood sugar, chemistry profile, complete blood count is also a good idea, as we've talked about some comorbidities medically that can occur with obstructive sleep apnea. And finally, conservative approach until diagnosis is confirmed, talking about sleep hygiene, talking about the patient doing a couple of other things that can benefit them if they have obstructive sleep apnea. Now, some of the steps that we want to take for Seth in his possible obstructive sleep apnea is making sure that he's not taking any CNS depressants. Also, we should advise him about reducing alcohol consumption, especially before bedtime. Sometimes if we tell our patients that they should try to sleep on their sides, this can make a difference in a good many patients who have obstructive sleep apnea. Now, good sleep hygiene measures are good for anybody who has any kind of sleep problems, and we'll get to this in a second. And finally, it's a good idea to start Seth thinking about losing some weight. What we find is that about a 10% weight loss is associated with about a 26% decrease in apnea-hypopnea index in one study. So the principles of good sleep hygiene. You see this all the time, but let's just make sure that we talk about some of them. What's really important for Seth is that he gets up at the same time every day, and for that matter, anybody who's having any trouble with their sleep. But it's also important that they're getting the right amount of sleep. Seth should try to go to bed when he gets drowsy or tired, and that's usually for most people about 7 or 8 hours before their normal wake-up time. He should maintain a regular sleep-wake schedule. He should try to decrease caffeine. We say about 4 to 6 hours before bedtime, but keep in mind that some people are very caffeine sensitive, and they may have to avoid it in the afternoon and on. Nicotine is not a good idea for any kind of patients with any sleep disorders, and obstructive sleep apnea is no different. Regular exercise is difficult for our patients sometimes to be convinced of doing, but it should be mentioned. And finally, the bedroom should be accommodating to patients. There should not be any noise, excessive light, excessive temperatures. The bedroom should be quite inviting for a good night's sleep. So Seth comes in 2 weeks later as per his appointment, and you see that he has a diagnosis established of obstructive sleep apnea based on the results of the study he had done. The sleep study suggests that in the first 4 hours, he had an AHI of 44, and he's desaturated down to 83%. And as most sleep laboratories do, he had a split study done where they wake him up after the 4 hours, and they titrate him with a CPAP mask. In his case, he needed 9 centimeters of water to eliminate all apneas and to normalize his pulse oximetry. Now, that morning after the test, he was seen by the respiratory therapist who showed him all the different choices of masks, and he picked one that he liked, and he's been at home with it. The CPAP machine also has a smart card which monitors his usage. When he comes in, he says he's been using the CPAP mask every night. He's trying to adhere to my instructions of going to bed the same time every night and waking up the same time every day. During the 2 weeks, also his laboratory tests have come back, and they're all normal. So at this point, he's advised to come back in 2 weeks and keep using the CPAP mask as directed. He's also advised to follow up with the sleep laboratory, as they usually like to see them periodically. So here's a graphic depiction then of what happens with a CPAP. Basically, it is a splint. As a result of continuous positive airway pressure, the throat and pharynx does not collapse, so the patient can breathe unencumbered throughout the night. Now, 2 weeks goes by, and the patient comes back again as instructed. He's still doing well. His sleepiness has appreciably reduced. He no longer falls asleep during movies. His girlfriend is happy. He's no longer snoring. In fact, his girlfriend at one point suggested, "Oh my gosh, I woke up in the middle of the night to make sure you were still breathing because it was so quiet." His Epworth sleepiness score is now down to 9. And so because of the CPAP doing so well, the patient is advised to follow up with the sleep laboratory every 6 months per their requirements, but also to return if any problems. Let's go to our next case presentation. This is Soji. She's a 45-year-old Native American woman who presents with a chief complaint of weight gain. She comes in saying to you, "Doctor, I've gained 15 pounds in the last 1 year, and I don't like it." She's 5'1", 175 pounds. She's been eating the same. She's not exercising as usual because she says she has no time or energy. And she admits to less interest and enjoyment than usual. She's less motivated. And further questioning suggests that she probably has moderate depression. Now, we know that she's had a history of depression, and she had been prescribed valproate and citalopram in the past. And because of her recently not feeling too well, she went back to her psychiatrist, who started her back on the medications again. Now, her social history shows that she's a full-time college Spanish teacher. She has a child in daycare, a husband at home. She doesn't drink, and she doesn't smoke, and she doesn't know much about her family history. Now, when you look at Soji, she looks tired. She looks frustrated. You can obviously see that she's overweight. She has a BMI of 33. Her neck looks somewhat large, and it measures 16.5 inches. You look at her Mallampati, and it scores 4. You basically can't see anything except the tongue touching the roof of the mouth. Her Epworth score is 16. So on further questioning, you ask a little bit more, because this woman really looks like she has obstructive sleep apnea. You ask her, "What does your bed partner think?" And she says, "I don't know. My husband used to say that I snore, but he hasn't said anything lately." She says that she does get drowsy in meetings, and while students are taking tests, but she doesn't really fall asleep. She has to struggle, but she doesn't fall asleep. But oddly enough, she has trouble falling asleep at night, even though she's really tired. And then she wakes up often for no reason, and when she does, she goes to the bathroom. You also ask her about anything else that she's been feeling. She says, "Yes, I wake up with headaches almost every day. And then I used to get these migraines in my past, and now they're coming back. Like a couple times in the last month, I've had really bad migraines where I've had to just go and lie down."